Attending conferences cannot provide solutions. Attending webinars cannot provide solutions. And many times we are left with situation where we need to innovate on table and wear a different hat. It's not a surgeon's cap, but an innovative hat where we need to do this called Jugaad. We have Guru of Jugaad here, Sanjeev, and he likes definitions, and he said that it has to be a flexible approach, and it has to be in limited resource environment, and it has to be an innovation. And I quickly asked him, instead of airbags, if somebody provides you pillows, is that a Jugaad? And Sanjeev told me, no, it's innovative, it is low cost, but it is ineffective. So it's very essential that whatever you think of as an out-of-box solution should be effective. And I'm going to share some of these situations which I've faced in real life, and get on to do things which were not described in books and found them to be effective. So then probably you can try. And I'm not going to write a disclaimer that try at your own risk, because they have worked, and if they have worked for me, they will work for you also. So one is using hypodermic needle to assist in pin direction while doing supracondylar pinning. We had a lecture on the complications, and many times what happens is once you have a supracondylar fracture and you reduce it, this is an arm board which has been designed by Dr. Sandeep Patwardhan from Pune, a very low cost device to help in reduction of supracondylar fracture. You slide it above the elbow, and then it allows you AP and lateral projection and allows you to translate and do all the maneuvers. And we've learned that this is a lateral oblique fracture, and very important nowadays is to appreciate this hourglass. When your hourglass is intact, your rotational problems are intact. But when you're passing the pins, many times a heavy drill and a pointed K-wire do not allow you very accurate placement of wires. So, based on one article which I read in JPO, I think let's me use these hypodermic needles. And once you put in a needle and take this AP view, seems to be okay, but little bit direction needs to be changed. And on a lateral view, this is anterior. Okay, this pin is put with the hand, it goes into the cartilage of the lateral condyle, it's not gone through the bone. And then you can, based on this, modify your K-wire position and pass one K-wire and the second K-wire. So this is how you will modify and pass that exact K-wire with minimum, sort of a fidgety factor. What I have also learned from Dr. Alan Crawford from Cincinnati is that you see here two different sizes of K-wires, and this is not because the sisters didn't have same size wires. This has been purposely done so that on lateral view, you know what is the direction of which wire. Many times it's confusing, and this is again a small Jugaad, what I have learned. And always we take not just AP and lateral X-ray, we take external rotation view. I call it as MEX view because it shows you the medial column, and a Lin view which shows you the lateral column. Okay, what about this fracture? So this is a different fracture. It is a flexion injury. Ulnar nerve injury chances are higher here. Irreducibility is high here. So push and pull method is something which is described for this. This child had ulnar neuropathy, and you can see there is ecchymosis on the posterior aspect, which tells you this was fall on the point of the elbow, and this resulted in the flexion type of injury. So in this injury, reduction is a problem. You cannot flex and reduce this fracture. You need to extend and reduce. But when you extend and reduce, you can see here there is a translation. Now, how do you reduce the translation? Because it becomes difficult sometime with push and pull method, but here the arm board helps. You can see this arm board on the C-arm image. It is little more proximal to the elbow joint, and with this arm board is being held with a micropore tape. So against that resistance, you can reduce the fracture in a lateral view and then pass 1, 2 and 3 wires to secure it safe. And you can see this healed well, and his ulnar nerve also recovered. One more small Jugaad here, we don't waste plasters. You have a plaster, sort of stall here. We use the fiberglass plasters, but we often use the same plasters and convert them into braces by applying Velcro and a liner inside. I use this all the time for my DDH, for my CP surgeries. We don't waste plaster and convert them into brace, because I believe in environment, and this is the way we can recycle and repurpose the same material. Intrafocal reduction for difficult situation, 10-day-old fracture with sort of an injury like this. Will you accept reduction or will you accept this position and do a late osteotomy for this patient? And that's a question. There was a mobility at the fracture here, and then we decided to reduce. And this is an intrafocal reduction which has been described with help of a K-wire. K-wire bends, K-wires are pointed. And that's why I said this is not a proper instrument. Let me use a mosquito forceps. And this is how we use a mosquito forceps, point it down, go into the fracture side and then turn it 180 degree around and then reduce this fracture. Now those of you feel this is just an animation, let me show you that it really works. And this is the video of actually it being done and not created by Leo, definitely. And this did give us little more radiation for purpose of education, but you can reduce this and then fix with a wire using an artery forceps. So difficult supracondylar fracture, this jugaad can work. Now we had a wonderful lecture on ununited lateral condyle fracture. So this is a lateral condyle fracture treated in plaster, did not heal, and then safe union for these patients. That is what we were told by Rashid. And then in these patients, what we have been doing now is based on this article, we do now close screw fixation, no bone grafting, no opening, but close screw fixation. So this was a 4-month-old fracture, and you can see it completely healed up, and the child had good range of movement with just a screw fixation. And we went little out of the way. The article described that you can do it up to 4 months, and we have treated non-unions up to 18 months post-injury with this method, provided that the fragment has not flipped. If the fragment is in opposition but in non-union, okay, then you can use it. The article said that the elbow stiffness must be corrected before you put a screw, but in our patients we accepted the elbow stiffness and noticed that after the union was achieved, the elbow range of movement came back in most of these patients. So elbow stiffness is not a contraindication for putting a percutaneous screw. So we concluded that this is a useful method and very safe method for treating non-unions in opposition, where you don't change the position but do a screw in situ. This probably works because the metal irritates and forms a callus formation and stabilizes and causes the fracture to heal. One more issue we always face is junctional distal radial fracture. These are neither metaphyseal fracture nor diaphyseal. Okay, and it's difficult. They will not be good enough for cross K-wire fixation. They are not good enough for a intramedullary elastic nail. And what do we do? This has been a bugging fracture for us. And what we, when we were stuck in this doctor's child with this patient, that we could not get a proper reduction, narrow canal in a girl child, could not get a cross wire, what we decided to align it with 2 K-wires. So we aligned it with 2 K-wires and then used a mini external fixator to connecting these K-wires to fix this. You can see that there is mild translation, and you can put a cross K-wire and then correct this translation again and keep this wire in place. So very simple way, not going across the physis, a low cost device to fix lower radius fractures. And again you can see after removal of the fixator, we put them in a plaster, and same plaster is used as a brace because there is a risk of refracture almost 30% with these patients if they fall again. Okay. Yeah, absolutely. So fracture of femur in young children, this was during COVID time, you can see, and this child had COVID and femur fracture. Now going by Mumtaz's recommendation, you would put elastic nail for this patient, but this child was not allowed anesthesia. So what we did is we put this child in a Thomas's splint for 2 to 3 weeks, and once the fracture became gummy, we applied a single leg spica. All this was done without admissions, without anesthesia. And I thought if this can work during COVID time, it can also work after COVID time. And nowadays, any patient whose weight is less than 20 kilo and has femur shaft fracture, irrespective of the fracture instability and telescoping, we treat them with a Thomas's splint spica on OPD basis, no admission, no anesthesia, because child will allow Thomas's splint without anesthesia, child will not allow immediate hip spica without anesthesia on day 1. And then we put a single leg spica on second or third week, and child can easily walk to the school and sit in the car. And you can see after 3 months, this patient has completely healed. Combination fixation for unstable femoral fracture. It is an unstable femur fracture and ideal indication for using a lateral entry femoral nail. That is what Leo would do in Australia. But we did not have this nail available in India. The child had a heart problem, congenital heart disease, and external fixators were contraindicated because infective endocarditis was a possibility, a valvular heart disease child. So what we did in this patient is a combination of nail and plate. So we put elastic nail to get initial alignment and then put a plate as a combination plate just with 2 screws above and below to give a rotational stability. And this is how the whole construct was done. We know that whenever we plate a femur, submuscular plate, they are at high risk for developing valgus deformity. And these children, it's recommended around 9 months you remove the plate to prevent occurrence of valgus deformity. One more problem which occurs in children where you put such a long spanning plate is that the distal screws are in metaphyseal region, and as the child grows, they go into diaphyseal region and the screw starts hurting. So you need to remove these plates. And what can happen is even when you remove the plate, a wire can still remain preventing a refracture in these children. So this is a combination fixation. So these were 7 sort of out of a box ideas. We have many more, but in 10 minutes, Sanjeev, I could describe only these 7 and okay, so tomorrow's lecture, then if those who want a copy of this presentation, I will just share a QR code. Thank you very much.